And this was what we found when we're dealing with a case of incomplete abortion, where the process, by one reason or another, has already started. Now we give the misoprostol, and in about 95% of cases, and the two groups here are just different dose or route of the drug. In one case it was a sublingual dose, in the other case it was an oral dose. Didn't seem to matter. Both times it was effective. And the number of people who actually needed any other surgical procedure was only about 5%. So that shows you that a single dose of the drug can be really effective in solving this problem with no doctors involved, just clinical diagnosis, no ultrasound, nothing fancy, a real field setting, very similar to the settings in which we are all working. Now, let's go to the next one real quick. Let me see. So the question I'll ask you guys is, so that you can sort of understand sometimes the difference between a clinical and a public health benefit, is if I have a group of people, why do you think that there might be such a huge difference between the 75 to 85% success that I showed you for the early pregnancy failure, where the pregnancy is still in the uterus, and the clinical incomplete abortion group that I just showed you for Madagascar? Why is that? Why do you think there's such a big difference?
The second is more recent.
The second, more recent study?
Oh, sorry, no,
the schmutz?
Is, more recently looked.
Okay, you're on the right track. The schmutz is more recently schmutz. That's, yeah, okay. What else? We're just dealing with what the patient says. I started bleeding, and I have been having some bleeding, and I don't feel good. Do something.
Is it that in the Madagascar case, maybe more of the abortions are actually complete?
Exactly. So the schmutz is more recent, but it's so recent that it's actually already gone. So in a purely clinical setting like this, we're probably dealing with a lot of cases where the abortion is already completed. But we don't know that. All we can do is say, it looks like an incomplete abortion, it smells like an incomplete abortion, sounds like an incomplete abortion, must be an incomplete abortion, we're going to give the best thing we know how to give for PAC. Now, you could make the same mistake and do that, and your only alternative would be surgery. Which is, if you had to err on either one of those two sides, which way would you err? Let's say I was in direct communication with God, and God told me that actually only 30% of these are true incomplete abortions. But I have to do something for all of them. Which way should I go? Should I do surgery for all of them, or give them some misoprostol? Exactly. Give them misoprostol, because even if the case we're over-treating, it's 2 pills, so now we spent 20 cents or something like that. Nothing really bad in the way of side effects, and yet we know that even if it were an incomplete abortion, it would work. So that's the public health rationale versus the clinical rationale. So we might be doing some over-treatment, but the downside of the over-treatment is relatively small. Is that clear? And the same thing really applies when we get to the postpartum hemorrhage side. Next. So let's keep going. These are just a lot of data. So I can talk about abortion for a minute. I could talk about it for 2 minutes, maybe. So this is a definition of abortion. I don't know if you can read this in the back. Intensely personal, medical, and emotional decision that can only be made between a legislator and his political party coalition. Next, please. But what I really wanted to talk about a little bit is about mifepristone and misoprostol. So this is the nut and the bolt of sort of medical abortion. Either one of them can work by themselves, but you wouldn't want to patent them separately, because they work better so much. They work so much better together. In the United States, it's a very unusual thing that the FDA did, because the FDA approved actually a regimen. It approved a combination of mifepristone and misoprostol. The only company that came forward was the company that was asking for mifepristone to be approved, what we used to call RU46. So that's the company that they asked for that drug to be approved, but it doesn't work very well by itself, so they brought in the misoprostol as part of the regimen, and in a very unusual move, the FDA approved this regimen. They just sort of ignored the fact that misoprostol wasn't approved for any OBGYN indication, but they approved this regimen. And so most of the time, if you're providing elective or provoked or induced abortion, you want to use mifepristone and misoprostol together. They work better in a legal setting. Next, please. Let's keep going. I just want to make a point about that. Let's keep going. Let's get to the postpartum setting. Let's keep going. Okay, yeah, this is the postpartum hemorrhage setting. So this is about treatment, and the big controversy. How many of you have heard stuff about postpartum hemorrhage before? Okay, a fair number of you. So then I'll ask you, what's the big controversy in the field of misoprostol and its relationship in the arena of postpartum hemorrhage? Shannon?
There's some other kind of drug that is administered via IV, Uterotonics, I think it's oxytocin, yes, exactly, that officially works slightly better, theoretically, than misoprostol. And the problem, I think, is that, as I understand it, there's more dangers associated with oxytocin, and it has to be administered via an IV and all that other stuff. And so some people say that, the benefits of having a orally administered, longer shelf life, safer misoprostol is better than the theoretical outcomes you can get if you have a trained OBGYN person using